Hello class, our PDSA project title is Utilization of Bed Alarms to Prevent Falls and Fall-Related Injuries. Our group members consist of Megan, Gabriela, Stacy, Kimberly, and Milagros.
Hi everyone, my name is Milagros. Introduction. Falls and fall-related injuries are one of the most commonly reported adverse events in hospitals and are a growing public health concern. According to the Agency for Healthcare Research and Quality, AHRQ, in the United States, falls occur at a rate of 3 to 5 per 1,000 bed days, and approximately 700,000 to 1 million patients fall per year during their hospital stay. Of those in hospital falls, about 30 to 50% sustain an injury, including serious injuries such as fractures and head trauma, and each injury on average adds more than 6 days to a patient's hospital stay. Inpatient falls can be classified into 3 categories. The first one would be the accidental falls, which occur from extrinsic factors such as clutter, inadequate lighting, and wet floors. Second one is the anticipated physiologic factors, which occur from intrinsic physiologic factors such as vision, changes in gait and balance. And lastly, the unanticipated physiologic falls, which occur from unexpected intrinsic events such as syncopal event or stroke. Issue identification. Fall prevention is complex and requires multimodal approaches. Fall prevention efforts begin with assessing individual patients' risk for falls, and according to the AHRQ in 2019, successful program must include a combination of environmental measures, such as in non-slip floors or ensuring patients are within nurses' line of sight. It requires clinical interventions, care process interventions such as using a standardized risk assessment tool, cultural interventions, and technological or logistical interventions such as bed alarms or lowering the bed height. For this project, the focus is on a single intervention, bed alarms, in order to testify if bed alarms work in preventing falls for patients who are at risk for falls while hospitalized. We think that lack of bed alarm use for all fall risk patients could contribute to falls and fall-related injuries. We think that if all patients who are at risk for falls have bed alarms, the rate of falls and fall-related injuries and length of stay will be reduced significantly, which will lead to a savings for both the hospital and the patients.
The Joint Commission and Centers for Medicare and Medicaid Services have regulations for hospitals regarding inpatient falls. The Joint Commission has national patient safety goals. Goal 6 and Goal 9 are related to inpatient falls. Goal 6, use alarms safely, means that healthcare providers utilize medical equipment alarms, in our case, bed alarms, and we respond to them on a timely manner when these alarms are heard. Many times, healthcare providers become desensitized to medical equipment alarms that we ignore it. Goal 9, reduce the risk of patient harm resulting from falls by initiating fall precautions as needed per patient. In 2008, Centers for Medicare and Medicaid Services stopped reimbursing hospitals for costs related to patient falls to influence hospitals to promote fall precautions for patients. Costs include imaging such as X-rays or CT, MRIs that are needed to rule out any acute injuries that a patient could have obtained from a fall that happened while being hospitalized. The hospital we use for our study is Loma Linda University Medical Center, the Murrieta campus. We focus on the oncology unit. In February 2021, there were 3 inpatient falls in this unit. 2 out of the 3 falls, the bed alarm system was not being properly used to prevent these falls from occurring.
Performance and financial impact. Falls can have a major financial and performance impact on the unit and or the organization. The overall average cost for a fall injury in the hospital is more than $14,000 per person according to the Joint Commission. When patients fall in the hospital, sometimes the responsibility falls on the nurse caring for the patient. In the oncology unit, one of the registered nurses was guilty of not taking initiative to prevent falls. Therefore, the management had to let go of the nurse. This can lead to the unit being short-staffed and nurses feeling overwhelmed with heavy nurse workload. In addition, losing a registered nurse in the hospital and replacing one can cause an increase in the organizational cost. The cost of replacing a bedside RN is about $40,038, ranging from $28,400 to $51,700 as stated in the 2021 Nursing Solutions National Healthcare Retention and RN Staffing Report.
As a group, we did a root cause analysis and found that patient doors being closed, bed alarms not being used, and bed alarm plugs not being connected were contributing factors for these inpatient falls in this hospital unit. Scope of the problem. When patients have an inpatient fall, there is an increase in hospitalization days, and these falls affect patients, staff, managers, and the hospital's accreditation. Patients have to have longer hospitalization days, and a new acute injury can occur from a fall. Staff will have to have a fall meeting to go over the fall with the unit director, educator, charge nurse, the nurse, and certified nurse assistant to determine what happened and what could have been done to prevent a fall from occurring. Managers. In our case, a nurse had to be let go because she kept having inpatient falls and was not being proactive in preventing falls from occurring. She was not using bed alarms or communicating with staff as needed. Hospital accreditation. The Joint Commission will audit the hospital and ask for solutions for inpatient falls and give a time period for these solutions to be implemented before a follow-up audit. Solution. Interventions to be used to reduce falls from occurring will include utilization of bed alarms and a fall risk sheet checklist. By utilizing these interventions, we will ensure LLUMC Marietta meets the Joint Commission National Patient Safety Goals 6 and 9. Once again, Goal 6 is using alarms safely, and Goal 9, reducing the risk of patient harm resulting from falls.
Hi, my name is Megan Baird, and I will be talking about solution implementation, or the do part of the PDSA. So in the month of February 2021, there were 3 falls on this unit, and falls are typically between 0 to 4 per month on average in the past year, after reviewing the data that the unit provided. We are hoping to decrease this number by implementing bed alarms on all patients considered moderate or higher fall risk. First, we needed to consider who is a fall risk and what interventions currently are. So fall risk determination is a computer-generated system using the Hester-Davis fall risk assessment and some individual assessment. So Hester-Davis considers the last known falls, mobility, age, medications, mental status, level of consciousness, awareness, toileting needs, volume and electrolyte status, communication, sensory, and behavior. Universal fall precautions on this unit are a low locked bed, clutter-free environment, call light and items of necessity within reach, communicate the risk at handoff, and a signage is identified by a magnet system that is pictured in this slide. So a low fall risk is 7 to 10 points. It's indicated by green. You implement the universal fall precautions in addition to education on risks and preventions of falls. Implement non-skid socks, a fall wristband, reorient as needed, remind them to call, and offer frequent toileting. A moderate fall risk is 11 to 14, which is indicated by orange. You implement the universal below, and then you use assistive devices with ambulation, bed and chair alarms, assist with activity and mobility, observe closely when out of bed, use a chair with the armrest. For a high fall risk that's greater than 15, it's indicated with red. You use universal precautions plus the low, the moderate, and then you do frequent observations and adequate staff assistance. So fall risk is communicated upon transfer of care for all patients. So there's no additional list kept on this unit to identify the rooms during that shift that are moderate or high fall risk. So that was something else that we wanted to look at. After determining the fall risk aspect of the project, we then needed to look at the bed alarms themselves. The bed alarms are built into the beds at this facility. The beds that are used are Hill-Rom. There is a bed for every room and no additional ordering of alarms was needed. The beds do need to be plugged into the wall to connect within the call light system and trigger an alarm through the system if activated. So if a patient attempts to exit the bed when the bed alarm is turned on and the bed is plugged in properly, the call light goes off and the staff member answering instructs the person to remain in bed and wait for staff while other staff run to the room. The current process is that when a bed comes from another unit, the bed is plugged in. However, there are no checks during the shift to assure attachment. Additionally, prior to implementation of the bed alarm, the bed is assessed for functioning, and if it is not working, will be tagged and pulled from the room until it is in working order. Another question asked was who was responsible for making sure the bed alarms are set of these high fall risk patients. Each member that ambulates or moves the patient is responsible for making sure the bed alarm is turned on prior to exiting the room. And at shift change, they should be looking at that. After answering the questions that came up, it was time to develop the steps to implement change. First, we will implement a basic list of what rooms have a fall risk patient of a moderate score or higher. Those patients will be placed on bed alarms when they meet that parameter, as is already the expectation. The implementation of the list is to identify who is at risk, and then there will be a checkbox for each shift change that will be checked to identify that the nurse made sure the bed alarm was on and the bed was plugged in. This will be done during handoff when introducing the nurse to the patient. There should be minimal effect on the workflow to perform the checks because it takes such a small amount of time, but there will be an additional step to check off the paper and make sure that the correct fall risk patients were identified and updated during the shift. This list will be the basis of tracking the amount of fall risk patients and bed alarms used. Ideally, a charge nurse, or another staff member like a secretary or aide would review the list and make a check on that patient and bed alarm to assure it is set and plugged in and check for compliance. This will assure accurate results of if the bed alarm is preventing falls because it was being used properly or if the staff is not being in compliance. This step would take additional time for another staff member, and it would vary based on how many fall risk patients are on the unit. Fall risk patients should be communicated to other staff to identify where there might be a potential alarm, which is another indication of a list at the nursing station. According to the fall risk interventions already in place, fall risk is communicated with the patient and family, and the addition of the bed alarm should also be communicated to increase compliance. Since this is supposed to already be being done, no additional workflow change would be made. So there are minimal effects on the stakeholders. For the timeline, the changes will be implemented in May, and after a 3-month period of using these steps, fall amount and causes will be analyzed.
To begin a financial analysis, we need to know the basic cost of the infrastructure. Each Hill-Rom bed is around $10,000. A full typically can cost around $14,000 per patient. Other than immediate financial impacts, falls consume significant time and attention, as nurses must be away from other patients and concentrate on charting the fall. The study shows that nurses spend about 34% of their time in the patient's room, and at least 26.2 to 41% of time on documentation. If
is time needed for a nurse to finish up work for the day. Overtime may be required. So for example, a nurse making $50 will make a $75 or $100 an hour for each overtime hour worked, which adds more cost to the hospital. Doctors also need to spend extra time examining the patient and may order imaging for suspected fracture. The cost of a CT can range from $270 to $5,000. The cost of X-ray can range from $100 to $1,000. Patients who have fallen may suffer as well from fall-related injuries. This will require that they stay in the hospital longer or may even proceed with the lawsuits later on. And as mentioned earlier in the previous slide, there is no reimbursement from Medicare or Medi-Cal. So what do we expect to observe from the strategy of using bed alarm to prevent falls? After the nursing assessment, nurses should determine if the patient is at risk for fall or not. They must make sure that the fall risk checklist is used. We have to realize that the bed alarm is only there to support a fall prevention plan that is already in place. At-risk patients may benefit from the extra layer of alertness that bed alarms can give. Universal fall precautions should also be implemented. A staff handoff can communicate the risk of fall. In addition, the unit also has a manage the fall risk sign outside the door. Nurses should always make sure the yellow band is on the patient's wrist. For administration, there should be a monthly and yearly report on falls. Most importantly, we hope and expect to see the reduction in falls in high fall risk patients. And what do we expect to learn? We expect to learn that the plan for using bed alarm is feasible. Then we will see the rate of fall decrease or even approach zero. After analyzing each fall, we can learn what other factors have not been considered or needed to be included. So how do we determine if the bed alarm has met the goals? We will evaluate the bed alarm implementation by looking at the fall risk sheet checklist usage during May 2021 to July 2021. We will also review cost analysis of any fall that occurs during this period as well.
If our fall prevention strategies, bed alarm usage, and fall risk checklists are successful in reducing inpatient falls, then we should recommend that the other units in the hospital implement them as well. Here is some data regarding falls that occurred in different units at Loma Linda University Medical Center for the month of February 2021. The data shows that these prevention strategies need to be implemented in every unit in order to reduce the incidence of falls hospital-wide. From this cycle, we concluded that nurses needed continuous education hospital-wide. From the start of their careers, nurses have been taught about various fall risk factors, yet they tend to become blind to these fall risk factors over time and forget to turn on the bed alarm. It's important that nurses are educated and reminded of fall risk factors so that they do not forget to turn on the bed alarm. For example, a patient that normally walks independently in the hospital is given lorazepam for anxiety. In this case, the nurse should be mindful that lorazepam can increase the risk for falls and turn on the bed alarm following administration. The patient will then need to be educated on this to ensure that he or she is cooperative with the bed alarm. Fall prevention is a collaborative process. This brings me to my next point. Nurses should know how to educate patients on fall risk factors, use of bed alarms, and waiting for assistance. As stated by Hoki and Zagani, nurses should educate patients that fall prevention is a collaborative process and that their engagement is necessary for understanding risks and implementing successful fall prevention strategies. Patients that are normally independent at home may not perceive themselves as a fall risk. Nurses need to have a conversation with the patient explaining why they are at risk for falling in the hospital. They need to repeatedly tell patients that they are at risk for falls and to call for assistance. Nurses also need to remind patients that they are not a burden and that calling for assistance is expected and appreciated. Doing so will increase patient participation with bed alarms and therefore reduce inpatient falls. Studies show that nurse storytelling using de-identified personal experiences of past falls can be an educational tool.
Thank you for watching our presentation. In the following slides, we provide our references.